Hello everyone, this topic is about hypertensive emergencies, urgencies, and severely elevated hypertension without any symptoms. We're merely talking about when in the cases that blood pressure is about 180 systolic and 110 diastolic. Hypertensive emergency is when the blood pressure is severely elevated. Usually it's more than 220 systolic and 140 diastolic, and there's acute organ damage or dysfunction present. Symptoms can include severe chest pain, severe headache, confusion and blurred vision, nausea and vomiting, and shortness of breath. In these cases, you should call an ambulance and emergently refer the patient to the ambulance because it needs an inpatient management of the patient. They usually start the management with infusion. Sometimes patient is given some IV bolus of hydralazine and metoprolol. Target is reducing the blood pressure less than 25% in 2 hours under observation. Hypertensive urgency is a severe and persistent elevation of blood pressure about 118 and 110 that is associated with significant symptoms such as headache and dizziness, or mild to moderate non-acute and organ damage or dysfunction. While hypertensive urgency is not immediately life-threatening, always consider factors that may increase the risk of hypertensive complication or affect the urgency of the treatment. So in these cases, we should also refer the patient to the hospital because there's some investigation need to be done, such as kidney function tests, liver biochemistry, urine analysis, ECG, to assess if there's any end organ damage or dysfunction. Treatment is done with oral therapy, such as captopril 12.5, nifedipine immediate release, clonidine 100 microgram, or prazosin 2 milligram. And you should know that they usually take 2 to 3 hours to start working. And the target is that blood pressure decreased below 118. Severely elevated hypertension without any symptom. Usually the blood pressure is more than 118 and diastolic more than 110. We should consider several factors in managing this patient. For example, patient's availability to come for outpatient follow-up and management, or patient risk factor that would complicate blood pressure, such as heart failure, ischemic heart problem, and kidney failure. If the patient doesn't have any problem, we could have the patient in the clinic and repeatedly measure blood pressure. Sometimes the blood pressure can decrease on its own without any intervention, but if the blood pressure has not decreased, or in fact it has increased, we can start oral therapy for the patient. If there's any complicating factor at this point, we can refer the patient to the hospital. In any patient presenting with severely elevated hypertension, we want to make sure if the patient has any complication from long-standing hypertension or any acute organ dysfunction. So the examination is focused on complete cardiovascular examination, pulmonary examination because we want to make sure if the patient has pulmonary edema or not. Fundoscopic examination, we want to particularly look for papillary edema or AV nipping that could happen in long-standing hypertension. Neurological symptoms, especially in urgency and emergency cases. We want to also do an ECG and urine dipstick because we want to make sure that if this blood pressure has had any effect on the heart or the kidneys.